And then at the end, we will have a panel discussion. So stay with us. We will have more discussion at the end of all the sessions. So to stay on time, I'm going to introduce our next speaker, Dr. Joan Sanchez de Toledo. He is an associate professor here at University of Pittsburgh in both cardiology and critical care. Also, he is an associate professor at University of Barcelona and the department chair at the Hospital Sant Joan de Déu in Barcelona, and the director of the Heart Institute there as well. So welcome, Joan.
I was saying that thank you very much for the kind introductions, and I will now share my screen, and please bear with me and just make sure that we all see the same presentation. Let me know if...
We see PowerPoint, just go into presentation mode.
Perfect.
Perfect.
Thank you very much. Unfortunately, I'm not here with you to enjoy this fantastic session. I am currently in Barcelona, and I'll try to go in the next 20 minutes through a difficult topic, which is the postoperative or the critical management of these patients. I have to cover from the preoperative to the postoperative issues of a very complex group of patients, and it might be too short of a lecture, and I'll be happy to discuss some issues after we finish. This is a complex slide, just to say that I have no disclosures, but the main one that I have that I think it's important to disclose is that I am now in Europe speaking to a North American conference about a very complex group of patients that traditionally have been treated very differently, both sides of the ocean. And I'm speaking about Europe because I'm European and I don't want to go any other place. Once this man, Robert Kagan, said that Americans are from Mars and Europeans from Venus, that they agree on little and understand one another less and less. So now I try to think, what am I exactly? I don't know if I'm European and American, and sometimes that's important because I don't know if I agree with one or the other or none of them. But when it comes to treating hypoplastic left heart syndrome, I think it's very, very important to understand where we are treating those patients and what is our environment, what are our cultural backgrounds, religion backgrounds, and what are the resources that will apply to that precise place that we want to manage those patients. As a general definition, I think that we have to focus on what we are going to do. We're going to describe management of a wide group of patients with similar anatomy and similar physiology, that on top of that, they have a lot of non-cardiac anomalies. And there is something very, very important. Whatever I'm going to say applies to patients that will end up going to one single pathway. I'll let you know why I'm saying that in the later slides. So the most important thing is to understand that, again, this is a rare disease, and by rare means that there is not a lot of centers that they do a great volume of those operations, that they associate high morbidity and high mortality, and that there is a lot of long-term consequences, not just to the patients, but also to the families, the society itself, and the whole healthcare system. Here on the right side, you could see the amount of expenditure related to each of the most common procedures, and you would see that the cost for a given number of operations overtake the rest of the operations by a significant increase. This is important, right? We said that this is a rare disease with a high morbidity and high mortality, but those are the raw numbers and the very striking numbers. Mortality based on STS, the North American data of the Norbut operation is as high as 14%. Same operation reported by the European Association is up to 22.8%. And as I said, that sometimes Mars is Mars and Venus is Venus. Within the hypoplastic left heart syndrome, the Europeans include biventricular repair as a surgical option, so nothing else to disclose. So some important facts, and you all know that. Prenatal diagnosis influence the prognosis. We know that protocolized pre- and post-surgical management also influence the prognosis. And we have been repeating over and over again that we need interdisciplinary and multidisciplinary management for those patients. Probably one of the most important things that we have to cover is how the prenatal diagnosis influence the postnatal risk to move forward with these procedures. And we know that there is certain preoperative risks, that being said, prematurity, low birth, having genetic abnormalities, and others such as having a sick patient intubated prior to surgery that will influence greatly the prognosis of these patients. And then, as you've seen in previous imaging discussions, there is precise anatomic variations and some findings in the anatomy and the imaging studies that will preclude for a bad prognosis. And before moving forward with management, it is important to understand that there's options, and the only option is not the surgical palliative path, but also there's other options that involve the termination of pregnancy, the postnatal palliative care, and I would say that less and less quoted in the literature, heart transplant is probably not considered now as an option from the get-go on those patients. But it's important to highlight that it's okay if people want to terminate the pregnancy. It's okay if postnatal palliative care is considered among the decisions that the family is willing to take for this patient. And this is one of the largest series that was studied at the beginning of this century, that study the outcome of prenatally diagnosed hypoplastic left heart syndrome. And if you see in the left side of the screen, that the outcome, if you compare to the amount of patients that are diagnosed and cover the amount of termination of pregnancies related to the diagnosis of a hypoplastic left heart syndrome. Over time, we have been able to change and to obtain a cultural change, and there's more people prone to go to the surgical palliation path. And you see that over time, since 1995 to 2012, there's more and more surgeries performed to those patients that once were considered not suitable for a repair. And of course, when we talk about management, we have to have clear some important concepts. We will need to stabilize the patient. We will need to allow time to get a precise anatomic and a physiologic description. We will need time to rule out other non-cardiac malformations. And then from the get-go, we have to invest on family education. We need to ensure that the patient, but also that our families are comfortable and that they understand that that's going to be a long path. And then understand physiology. And there's some concepts that it's important to have clear before treating those patients. We need to understand what QPQS means, the effects of pulmonary overcirculation on the end diastolic volumes and pressures of the right ventricle, how those things will affect the coronary perfusion and the systolic function of this solo right ventricle that will pump two circulations. Probably the most important thing, and it's not time now to spend with physiology descriptions about the importance of the Fick principle, but this is probably the most important equation when we try to teach during rounds about a pre and postoperative management of the single ventricle physiology. That being said, this equation has a lot of problems and can mislead us a lot. So in the ideal world, we always look for a balanced circulation, QPQS of 1, but that's never the case. And not just that's never the case, but a bad interpretation of our data will mislead us to make assumptions that do not apply to our patient. Understanding that this is an equation that has a lot of false numbers and hidden numbers might help us understand that it's very difficult to relate and translate this equation to the clinical bedside. And what I'm trying to say is that since we don't know the real number of the pulmonary vein saturations and that we don't know exact numbers of the mixed venous saturation, the equation can change and could mislead us a lot. So the main goals for management of these patients preoperatively are summarized in this slide, but essentially we have to ensure systemic circulation. We need to minimize pulmonary overcirculation. We need to make sure that the patient is comfortable, that we save some venous access for what is coming in the future. And then we have to be diligent assessing and protecting the function of all the organs. So in summary, what we need to do in order to prevent for early pulmonary overcirculation is play with our pulmonary vascular resistances, try to increase PVR, try to support function of the heart, decreasing afterload, decreasing systemic vascular resistance, and trying to unload the heart with early initiation of diuretics. There's a lot of discussions of how to manipulate PVR in the preoperative setting. What's clear is that there's only two strategies. One is by positive pressure, and the other one is by inhaling a gas, whereas hypoxic mixture of CO2, that's another question. The effects of positive pressure are clear, and we need to go back to the physiology to understand how the relation progress between the increased volumes of the lungs and the increased PVR and the decreased volume of the lungs at electrolysis with increased PVR. So what we try to do in the preoperative management is put those patients on a little bit of positive pressure, non-invasive ventilations, high flow nasal cannula, CPAP, to try to achieve a little bit of over distension to increase the pulmonary vascular resistance. Much has been written about the effects of CO2 and hypoxic gas mixture on those patients. Albeit the initial reports from Dr. Tabot, also Gil Bernowski, were not that keen about the use of hypoxic mixture. We now know that the effects of hypoxic pulmonary vasoconstriction in the lungs will benefit those patients preoperatively. Those are the initial papers from Sarah Tabot and also Gil Bernowski, trying to make the case where CO2 or hypoxic mixture was better for those patients preoperatively. If we go down and we dig in the data of these papers, the conclusions are not clear. And the conclusions that apply in 2001 probably do not apply on these ones, on the current era. This slide is important just for you to understand that when we talk about the effects of hypoxia, we have to always keep in mind that hypoxia will be artifact by acidosis. If we have a given PaO2, but on top of the PaO2, we have a patient that is severely acidotic, the effects on the PVR will increase dramatically. So yeah, we have to control the oxygen, and we could achieve hypoxic mixture, but we have to always keep in mind that these patients should be on a very control level of pH. There's many publications now that support the use or that could support the use of hypoxic mixture in the preoperative setting, but as I said before, this is not the case, and this is now outside of the scope of this talk. As a rule of thumb, at least what we do here in Pittsburgh, to make sure that these patients get to the operating room in a relatively stable condition, is a protocol that was described a long time ago by a very well-known colleague of us that described the use of milrinone, the combination of milrinone, high flow nasal cannula, hypoxic mixture, and early initiation of diuretics in all of the patients that were going to the Norwood operation. What happens in the postoperative period? So the postoperative period is exactly the same. We need to ensure circulation, we need to minimize overcirculation, and we need to assess and protect multi-organ function. Provide comfort to the patients, safe venous access, and make sure that we give and we start to provide good nutrition to those patients. Probably something that is very important is to understand what, who, how, and when is going to do, and when we're going to do the operation. The what is very important. Are we going to do a Norwood BT-Shan? Are we going to do a Norwood Sano? Are we going to do a hybrid? Who is going to do it is very important, but it's also outside of the scope of this talk. We always want the best to do it, no matter sex, country, place. There is always a good surgeon that could do the best surgery. But then it's important to understand the details, the intraoperative details. Are we going to do deep hypothermic cardiac arrest? Are we going to do cerebral anterograde perfusion? How long is going to be the rest? All those things will matter and will translate to the postoperative period. And then the when. Are we going to do an early Norwood? Are we going to do a late Norwood? This is a paper, a provocative paper from Gil Bernovsky, the group of Children's National, that now they are advocating to postpone the Norwood procedure to a later stage. Whether they are right or not, there is just we just need time to know it. This is the summary of what we do. Hypoplastic left heart syndrome can go to either the stage 1 BT-Shan or RB to PA conduit. Once we said that it was related to morphology, but probably now is more related to an institutional approach. And then there is some particular cases, the high-risk cases that are associated with comorbidities, low weight, etc., that they should go straight to the hybrid approach and try to prevent for the surgical morbidity and to displace the surgical morbidity to a later stage. This is a slide that tries to summarize the effects, the physiologic effects of the three main surgeries of these patients. So if we do a Norwood BT-Shan, the impact on QPQS, it's going to be significantly higher than the one that will have an Norwood operation with an RV to PA conduit, or also the one that the hybrid approach will have. The VT shunt will have an increased pulmonary overcirculation. The right ventricular end diastolic volume and the end diastolic pressure will be high, and therefore the coronary perfusion will decrease, and the RV systolic function will be impacted in a higher level than the rest of the surgeries. To the contrary, when we do an RV to PA conduit, even though we are still in a pulmonary overcirculation stage, the the right ventricular end diastolic volume and then diastolic pressure are not probably as high as on the VT shunt, and therefore the coronary perfusion will stay more stable through the course, and the RV systolic function might be a little bit better than the other cases. And if we take the example of the hybrid, just having two restrictors of flow, both in the PAs and also in the PDA, might have an impact on the afterload and might have a significant decrease of the RV systolic function of those patients. So all those things need to be into account when we receive a patient, and then we need to anticipate what is coming. And we need to anticipate bleeding, the low cardiac output effects, the high likelihood of arrhythmias, the presence of acute kidney injury, the importance of neuromonitoring those patients to prevent CNS dysfunction, and other comorbidities that might appear during the postoperative period. I just want to highlight a couple of things that are important in the postoperative management. One is the meticulously assessment of fluid status, and to make sure that the fluid that the patient receives has an osmotic power that doesn't worsen the overall hypervolemic status of these patients. So it's always better to give albumin, to give FFP, or to give colloids to these patients in the immediate postoperative period, that giving crystalloids and putting free water into the intravascular vessels. One of the things that we have learned over time is that we should not give volume trying to chase numbers. Too much volume is associated with morbidity. We have learned that from the sepsis literature, and we know now that after years of giving too much volume, we have been negatively impacting the course of our patients. And this is particularly important in the ICU. In a patient that has a decrease ventricular performance with an increase in diastolic volume and an increase in diastolic pressure, giving volume, if he doesn't need it, will negatively impact the coronary perfusion and might trigger an arrest. So yeah, just give volume, but just the right amount to our patients. And then we have to support cardiac output. We have to use drugs, but the less the better. And just try to stay away from dogmas that might not apply to our patient population. So if you see this slide, you don't see milrinone. So sometimes we just take things for granted. And those patients that do not need milrinone, they should not receive milrinone. We know that there's studies that have changed the course of cardiac ICU, and I'm relating to the Primacore study that extended the use of milrinone. But sometimes just treating patients because studies that do not apply to that particular anatomy say so might be detrimental for our patients. Another important thing is understand arrhythmia, how to treat arrhythmia. Try to easily identify the mechanisms that translate to treatment. It's easy to treat a re-entry tachycardia in the postoperative period. It's more difficult to treat an automatic tachycardia. If we have an automatic tachyarrhythmia in the postoperative period, we are probably talking about junctional ectopic tachycardia. And if we are talking about re-entry tachycardia, what we have to do is to diagnose it and treat it appropriately. Our patients are always brought back to the CICU with atrial wires, which give us the opportunity not just to diagnose, but also to treat in the event of a re-entry tachycardia, or to pace them in the event of a bradycardia, pharmacologically induced or a surgically induced. At the end, I think that there is important concepts that we have learned over the years about how to best manage those patients. And I try to highlight those ones here in this slide. I think that those are probably the most important things that I have learned from managing these patients over years. I now understand the importance of the delayed sternal closure, trying to not just to minimize the amount of a transmural pressure that affects to this ventricle, but also impacting on the interpersonal variability in the immediate postoperative period. Having a patient with open chest ensures that the patient will be with sedation and paralysis and will avoid swings in opioids or other medications. A peritoneal drain that just passively drains the belly content will help achieve a negative fluid balance necessary to recover the myocardium, and also will help to restore the diaphragmatic organ perfusion. I said that the importance of the neuromuscular blockade in patients with delayed sternal closure, but also the decrease on the inputs that those patients have will also help to decrease the amount of sedatives that we will need to deploy to achieve a good comfort control of these patients. So that is, try to minimize the amount of sedative in order not to impact negatively to the hemodynamics of these patients. Try to provide a rational approach on our inotropic support, try to do less, and try to minimize the amount of drugs. It's easy for us to put a lot of things, but the really difficult thing to do for an intensivist is to know how to decrease, when to remove things, achieve a good temperature control, and obviously continuous neuromonitoring throughout the case to avoid and to anticipate neurological complications. It's important to have a start as a surgeon. We need a good team, but we need to work as a team. And we know that from years and years of working in ICU. It's not about one person. It's about a team that works together. So we need to be prepared. We need to anticipate. We need to monitor our patients. We need to diligently follow the trends. And something that is very, very, very important, you have to be quick, but do not overreact. Just bring the team to the bedside, work together, and try to keep things as simple as possible. In an ICU, it is easy to make something very complicated and keep adding things, but the really hard thing to do is to keep things simple. Thank you very much.